Good afternoon, welcome. We're just waiting a few minutes as people join the webinar. Thanks so much for joining today. Good afternoon, I'm starting to see more people join us, so we'll just wait 1 or 2 minutes as people join before we get started. Thanks so much for joining today's webinar. We're really looking forward to this session and looking forward to hearing from our speakers and also having an opportunity to engage with you and hear your questions and hear your experiences about what's been going on. So thanks again for joining. So I have 12:02, so let's get started. My name is Sebastian Tong. I'm one of the program officials in the Center for Evidence and Practice Improvement in the Agency for Healthcare Research and Quality. By background, I'm also a family physician, and welcome to today's webinar on primary care research during the COVID-19 pandemic. During today's webinar, we'll have the opportunity to listen to some of the experiences from some of our unhealthy alcohol use grantees, and also have an opportunity to engage in questions and also share experiences through this webinar. If we could have the next slide. So to start off with, we just have some housekeeping items. If you're hearing me speak, you've obviously figured out how to join the audio, but you can also join if you want via phone. And if you have any technical difficulties, feel free to put something into the chat to our panelists, and we will try to help you as best we can. Next slide, please. So this webinar will be recorded for future posting and use, so it will be available after the meeting on the ARC website. Other participants, because of the size of the webinar, are muted right now, so to ask questions, you can see on the bottom of your slide a Q&A box. So we ask you to put all your questions in that Q&A box, and the panelists will answer your question live as time allows. Next slide. And this just shows you where the Q&A will be. You'll be able to see only your own questions, and then when your questions are answered, you'll be able to see that as well. Please put them in the Q&A box and refrain from putting them in the chat just so that we have a coordinated place where we can see the Q&A questions. Next slide. So today what we'll be doing is we'll be starting with introductions, and then we'll hear from both Perry Dickinson and Melinda Davis, who are two of the principal investigators from our Evidence Now Managing Unhealthy Alcohol Use initiative. Then we'll have a question and answer period, followed by some closing remarks. But to start off with, I want to invite Arlene Bierman, the director of the Center for Evidence and Practice Improvement, to give some opening remarks. Thanks.
Hi, good morning or good afternoon, everybody. Thank you very much for joining the webinar today. ARC's initiative to improve the screening, diagnosis, and management of unhealthy alcohol use in primary care is part of our overall dissemination and implementation initiative aimed at increasing the uptake of evidence in practice, as well as building the evidence base for how to most effectively improve care delivery. In addition to improving the management of unhealthy alcohol use, we want these projects to teach us about the most effective models of integrating behavioral health in primary care. And the COVID pandemic arrived just as the grantees were recruiting practices. And we all know that at the same time, the pandemic has resulted in increasing alcohol use, making this initiative all important. And so today we're going to learn about how two different projects have found solutions to the challenges that they've encountered in keeping these projects going in the face of the pandemic and the challenges faced by primary care practices. Thank you.
Thanks so much, Arlene. So to start off with, we want to get a sense of who is in the room. We had about 143 people register for today's webinar, and we have close to 100 people right now in the room. Unfortunately, given the size, we can't have everyone do introductions, but we wanted to do a poll to see what region of the country you're from, and also what is your professional background, and you can choose multiple things at this point. So I'm gonna have you should have the poll pop up on your screen, and we'll give you a minute to just answer what region you're from, and then what your professional role mostly is. So if we have enough respondents, we can close the poll and just show some of the responses. Great. So it seems like we have the most people from the Midwest, about 33% from the Midwest, but a good mix from different parts of the country. And then it sounds like most people, about 50%, identify as being a program manager or a researcher. We have a good mix of practice facilitators, clinicians, some policymakers, and then about 32% who identified as other roles as well. Great. So what we're going to do now is introduce our first speaker, who is Dr. Perry Dickinson. He is a family physician and professor of family medicine at the University of Colorado in Denver. He is the PI of our grant, Unhealthy Alcohol grant from Colorado. He has done a lot of work in practice innovation, and I'm very excited now to hear from Perry. So Perry, go ahead. Perry, we still have you on mute right now.
I'm sorry, I'm having difficulty getting my screen up. Give me just a second, but can you hear me?
We can hear you, but we can't see you yet.
I'm sorry, my control, when I took over the control of the screen, I lost my ability to show my picture. That's weird.
Perry, that happened to me too. If you give control back, you'll be able to access your camera and then take control over again.
Okay. Let me give up remote control, put on my video, and then we'll do this again. Sorry for that. All right, so we'll start now. Apologize for that. Now I can't control the screen. There we go. Let's go back if I possibly can. Here we go. All right. So the objectives for the presentation today are to, first of all, just briefly introduce our unhealthy alcohol use project, but really focus the bulk of the presentation on just a discussion of the immediate impact and subsequent impact of the COVID-19 pandemic on practice engagement. We'll talk about how we quickly pivoted our project to maintain some momentum despite the pandemic hitting, but also describe the reluctance that practices have had to engage in any sort of project over the last summer through the winter, and the kind of gradual reemergence now, as well as talk about what I think will be the long-term impact of practice engagement and studies around the pandemic. So first of all, let's just do a quick review of the Facilitating Alcohol Screening and Treatment Project, or FAST. This was designed to assist 125 Colorado primary care practices in implementing screening and brief intervention for unhealthy alcohol use with medication-assisted treatment and or referral for treatment for alcohol use disorder. We had a study within the study in that we also had in randomization of the practices to two different groups to compare a couple of different interventions. One was in-person practice facilitation, which is kind of traditionally what we've always used, having people go out and meet with teams in the practice to really do the implementation of the change package with the practice. And the other, a form of virtual practice facilitation using e-learning modules to really structure the sessions so that the practice facilitator and the people in the practice would be sharing their screens and then using the e-learning modules to work through the content of the session as a way of really structuring the virtual facilitation. We were doing a non-inferiority design, looking to see if the virtual facilitation with the e-learning modules actually could be as effective as in-person practice facilitation. So we got off to an early start, fortunately. We had a group of practices that were interested and had 30 practices actually recruited and ready to start going into March when the pandemic hit. And at that point, practices either shut down or certainly constricted their care. They had very limited care that they were delivering. The ones that were really the most functional started focusing most of their attention to pivoting to telehealth capability. The practices basically were swamped and really weren't at a place where they could participate in a project. In addition, in-person contact with the practices just wasn't possible. So our in-person practice facilitation arm became basically impossible to do at that point, and also was unlikely to become possible consistently in the near future. So we had to really look at our study design. Across a lot of places, the IRBs started shutting down practice recruitment for studies, and in some cases that's still the case. There are IRBs that are just now beginning to allow practice recruitment for studies. The way we had our IRB structured, we actually were not shut down, but still we didn't think we could really bug the practices to engage in our project at that particular point, plus the project wasn't really possible. After a month or two, some practices began to realize that they actually had time for project participation. They had switched over to some telehealth capacity. Their volume was lower than usual, and they started pecking at us to say, well, now would be a good time for us to do the project. So we quickly pivoted our design of our project to an all virtual sort of framework, where we were comparing virtual facilitation, kind of just a standard virtual practice facilitation, to virtual with the e-learning to see the benefit of the e-learning modules, to the added benefit that they gave, just helping to structure the sessions and perhaps make more progress than just with the standard virtual facilitation. We got that through the IRB. That was a slight delay, but then we began work with the practices that were already enrolled in the project in late June. So as we went along, we started finding that several things were happening with the practices. First of all, they were hit hard financially and operationally, in that their in-person visits had decreased drastically. The virtual visits that they were doing weren't paying as well. They had clinicians and staff members who became ill, and then with the financial issues, they had people who were laid off or furloughed. So they were working short-staffed. People were getting a bit burned out at that point. And for some of the practices that were part of a little bit of a larger system, particularly those that were affiliated with hospitals, we saw that some of their staff members were actually shifted to other duties, either inpatient care because the hospitals were being slammed, doing testing, and then more recently enlisted for vaccine delivery. And one of the things we found is that there were extremely high levels of stress and burnout through all the practices. I actually had a group of practices that were doing the burnout scale kind of serially, and they went through from a burnout level that was below the national average, that's right around 25%, having some sort of significant burnout, to having about 70% of their clinician and staff members expressing a pretty good degree of burnout. So this was a period of a lot of uncertainty. And one of the things the practices we're dealing with, this is kind of looking at things as through late summer going into fall, practices were looking ahead and seeing that they were really unsure as to what was going to happen. Was the pandemic going to make enough of a secondary or tertiary surge to where the practices would be shut down again? When were the vaccines going to be coming around, and what was their role going to be in delivering vaccines? And basically, with the burnout, the stress level, the lack of staff, et cetera, we found that practices were just not willing to take on anything new. So we would talk to some of the practices at that point, and they'd say, I'm really interested in this project. I recognize the level to which alcohol is a problem right now, and feel like this is something we need to do. But if you ask me for an answer right now, it'll be no. Come back and talk to us next spring. So we honored that. We basically managed to complete work with most of our enrolled practices. We had a few that went on a hiatus for a little while when some of the chaos struck, and kind of put the project on pause for a few months. We also added a few more that kind of came up and that we had talked to previously and said, yeah, I think we could take on this project now. But we actually put active recruitment on hold starting around late summer and going through the beginning of the year. Practices approached us, we would talk to them, but we did not do any active recruitment at that point. Okay, let's see if I can get it going forward. Shoot. Okay, there's a delay after I push the button, sorry. So where are we now? Well, the practices are slowly beginning to thaw out. We have practices that definitely are beginning to be willing to consider taking on a new project, although we have some practices that have just said, for the near future, we're not going to consider any new research project. There's actually a couple of groups of federally qualified health centers that we have worked with extensively in the past. They're just saying, we're just not even going to talk about any new projects. The practices that we are talking to still have typically a preference for holding off for a few months, perhaps a start this summer or next fall. The in-person contact is still problematic, but across some of our other projects, it's slowly becoming possible. So, in this project, we structured things to where we did not have to rely on in-person contact with the practices, but in some others, that's beginning to become a possibility. The practices kind of universally are more selective and practical. I mean, if they're willing to consider any new projects, they have to fit into their needs and priorities. So you do have to really do some sense making for them to see how this project that you're talking to them about really fits with things that they need to be thinking about and prioritizing at this stage, more so than has ever been the case in the past. For our unhealthy alcohol use project, we've begun active recruitment again. We have some practices that are engaging. We're up to 55 practices now that have either completed or working on it now or are going to engage over the next few months. And we have others that haven't said yes, but are really interested and are waiting until summer. So we have moderate confidence that we'll be able to hit our original target. Obviously, it has delayed our recruitment and it's taking longer, however. So the future, that's hard to know, but I think there's going to be a fairly good bit of long-term impact. It's going to take a while for the practices to recover, first of all. I mean, some of our practices have weathered the storm pretty well, but there are a lot of the smaller independent practices that we work with that have really struggled through this, and it will take a while for them to recover financially and operationally. I do think that the fit of the projects to the practice's priority and the extent to which it really builds capacity that they feel like they need to build is likely to be even more important in the future than it has been in the past. I think the patients for projects that require patient recruitment, we're seeing already that they're more wary of contact with the healthcare system, but also researchers. And that may be the case for a while before that levels out, if it ever does. All of our projects have had to adjust to the impact of telehealth. And certainly, as we look at the impact of the pandemic on the practices and on our studies, any of the projects that are relying on measurements of care trends, including projects that are using clinical quality measures to measure the impact of the project, are going to be disrupted. The clinical quality measures in some key areas have really been distorted. And so there's a lot of the signal to noise ratio there has really been impacted. So we have to take that into account as we're looking at the impact of our projects. With that, I'm going to pass it on over to Sebastian and Melinda. Thank you.
Thank you very much, Perry. You gave some very valuable insight about your project and how things have worked out from your end. So I'm starting to see 1 or 2 questions pop up in the question and answer. If you have anything you're noodling about, thinking about, feel free to pop it in the question and answer so that Pierre can take a look while Melinda's talking. So we'll introduce Melinda Davis next. So she is an implementation scientist and associate professor of family medicine at Oregon Health and Sciences University, and also the director of research for the Oregon Rural Practice-Based Research Network. She actually started off her career as a practice facilitator, so has kind of boots on the ground experience doing practice facilitation before she went and got a doctorate. So I look forward to hearing what Melinda is going to talk about as well. Melinda?
Great. So I think you can see me and hear me. We'll see if I can control the screen. So really happy to be here and to share some insights in what has been happening in Oregon over the past few years as we've been responding to our situation here. So my goals are just to, like Perry did, summarize our project in Oregon. I want to take the perspective, Perry did a really nice job of kind of summarizing how the pandemic's impacted practices. And I'm just going to highlight 3 phases and how our team has kind of responded and tried to rework our recruitment approach and engagement approach. And then just spend a little time reflecting on lessons learned. And I do see some of those questions coming in, so looking forward to addressing those at the end. So our project is called Antecedent, or Partnerships to Enhance Alcohol Screening, Treatment, and Intervention. If any of you need a fancy acronym for a study, I encourage you to look at Acnimrify, which is a website that'll help you. We were super excited to see the original request for this application and to put in a submission because of the partnership approach we were using. So what's really exciting about the Antecedent study is it leverages the infrastructure of our established practice-based research network in Oregon, but it's also a partnership with John Munch and his Esper Oregon website, which is just a wonderful resource developed over many, many years to support implementing evidence-based approaches for addressing unhealthy alcohol use and drug use in primary care. And then we also partnered with the Oregon Health Authority Transformation Center. And so the OHA is responsible for helping evaluate implementation of Oregon's regional coordinated care organizations, which are the Medicaid providers. And we were super excited for this partnership because OHA in 2019 was reintroducing a quality incentive metric for SBIRT, so screening, brief intervention, and referral to treatment. And then what you see here on the map is just our regionally based practice facilitators. So we had 6 facilitators planning to work on this project. ORPRIN is based in the urban center of Portland, but our regional facilitators really help build relationships with practices beyond individual studies and kind of hold that local knowledge for communities. So we had 3 study aims that you see on this slide. The first was to engage, recruit, and conduct intake consultations with our target primary care practices. The original target was 150. I think you see the 80 here. This was a mental math, I think, internally to try to help our team keep going in some of the early stages of COVID. The second aim was to really implement and describe how facilitators tailored implementation support based on local context. Our intervention is designed around foundational support and then supplemental support that again is 12 months of support based on practice needs and context, and then to evaluate the impact of these supports and really look at their impact on screening, brief intervention, medication-assisted treatment in these participating practices. So on this slide, you see the original timeline. You can see that the project launch happened in fall of 2019. And then we had planned to have staggered implementation over a quarterly period, basically so we could reach our 150 target, and then also have time at the end of the project for evaluation and dissemination. We had always planned to kind of have a pilot, a smaller number in our first wave of the project, which was to start in February 2020. But then the numbers really increased over time. But as was said, many of you know that starting in March, we had a lot of restrictions and challenges because of COVID, both in terms of everyone moving from a usual norm of going to practices, both to support recruitment and project implementation, to working from home and research restrictions, as well as the various impacts that we saw COVID having on the practices, as Perry described. I was thinking though, I think the other thing that's been really challenging about this year is not just COVID, but some of the other accumulative stressors that we've had in the environment. So I think we've had a lot of challenges with social unrest. We've had kind of a volatile political climate in Oregon. And I think nationally, there have also been lots of climate crises. We had some of the most severe fire conditions in the fall of 2020. That actually burned a number of our clinics and communities. And then within our organization, shockingly, we've doubled in size since fall of 2019. So when this project launched, we had about 19 staff members. During the time we've all been working remotely, we've grown to an organization of about 50 staff members. So I think there have been a lot of additional factors in addition to just COVID, which have made the last year challenging for people. So in the slide here, what you can see is there are 3 colored bars for each wave of the project implementation. The darkest purple is the recruited clinics. So these are clinics who have signed a participant agreement letter indicating that they would like to participate in the project. And you can see the bullets of these obviously were collected before the pandemic hit. What you can also see is the second purple line is anticipated start. So one of the unique things about our project is that rather than randomizing clinics to a wave, we allowed clinics to select what's the quarter that would be best for you, that where you think you might have the most capacity to engage in a project like this. And what you see is that, you know, again, we had that smaller pilot in February as planned, but a number of the clinics actually had anticipated starting in May or July. What you then see in the lightest purple is that many of the clinics had to delay that start. So you can see a small number, about 12 started in May and July. 7 August, smaller number in November. And then a lot of the clinics are, as Perry said, kind of starting to thaw and hoping to initiate work in this current quarter. So from a recruitment standpoint, we had what we call as a team kind of 3 phases. There was our plan phase before COVID, where again, we thought this was going to be totally achievable because of the robust structure we had in the original project design. In April, we have a kind of poop hits the fan phase where really I think a lot of the team was just trying to make sense of what was happening and how long this would keep going on for. And then now moving into a new normal where we have a little bit more of our footing underneath us and can start thinking about strategically, how do we maybe re-engage some of the practice sites? So the initial plan, a few just things to highlight in terms of how we were thinking about engaging. As I mentioned, we had aligned with our Medicaid health plans and we were really tapped to be the technical assistance support at the state level for both our payers, partners, and the clinics. One of the other exciting things is you might think in your state, there's a comprehensive list of primary care clinics, but what we found in Oregon, there was not a list. And so with this study and a few others, we were able to put together a kind of master list of all the clinics in Oregon to identify prior contacts that we had worked with on projects, and then really to try to leverage that to support recruitment. In line with prior work, we plan to have facilitator-led outreach and engagement. We had talked with our team and advisory board to really highlight what were the kind of hooks for clinic participation, including providing maintenance of certification support, aligning with, Oregon calls it PCPCH, but that's patient-centered medical home attestation, and then actually aligning the project with another project, which was about chronic pain and opioid prescribing, because again of the state SBIRT metric. And then really highlighting that, this is not a one size fits all approach. It was really designed to align with clinic context and needs. As you can see here, these were some of the messages that we were using initially, including highlighting the benefits of the program, really focusing on the clinic and how this could align with their existing priorities and efforts, and then highlighting prior relationships in the sense that we've worked with many of these clinics, we're well aligned with the CCO partners, and our job is really to complement what's going on in the practice. So then March and April, I think the main thing is to remind everyone, it's really easy, I think, to rework our memory of what was happening in March and April and all the uncertainty and all the surprise. So one of the main things is just breathing deeply. I think also ARC has done a really nice job of bringing the R18 partners together for monthly meetings. And so really trying to listen and understand what the other sites are doing. So what is even allowed here? This is a 3-year study where we had certain benchmarks and metrics we had been challenged to achieve. And so these were unprecedented times. Is it even appropriate for us to pause, and how much can we pause and rework our plan? Our team kind of did a both and, meaning that for clinics that were engaged, we really tried to focus on helping them think about, can we delay the start if they do have some capacity? Because as Perry said, there were some clinics who their staff were eager not just to think about COVID, but to try to move some other pieces of their normal work forward. We did still outreach to clinics, but much of that was really focused on trying to listen and understand what the clinics are doing, and then to connect them to other resources. For example, within our network of ORPRN, we also hosted a COVID echo. And so really just trying to listen, provide support. And if it's not our current antecedent project, are there other things we can do to let our partners know that we care and that we're thinking about them and we want to see them make it through this time? So these were some of the messages. We care about you. We also highlighted that behavioral health and substance use is increasing in response to COVID. And then again, reiterating the flexibility that was built in the project. So emphasizing that we can, if they're interested, we can delay that start time. The support provided can really be tailored to practice needs, and just emphasizing that we understand that this is a really complicated time. As we move into the spring, as Perry mentioned, We've started some other lighter or alternative recruitment methods. So we are hosting a webinar series. One of the things we saw in some of the other work our network was doing is that folks seem to have capacity to attend maybe a 1-hour webinar, but sometimes they were hesitant to engage in the bigger projects. We've started to re-engage our partners, so reaching back out to the CCOs and really trying to see where are they at, because we also saw across the state and with our Medicaid payers, everyone was responding. So even the quality incentive metrics that were planned for 2019, those were actually in 2020, those were dropped. And so some of those levers are being revived as everyone starts to think about, okay, how do we re-engage now that things are maybe normalizing a bit more? We also have shifted within ORPRN to doing more ORPRN-wide recruitment and building a customer relationship management system that can help us look across all of the projects that we're outreaching to clinics around. And then we've shifted really from a PERC-led model to a project manager and PI-led model, in part, I think, because some of our facilitators were relatively new to the position. And I think the uncertainty and the hesitation from the clinics was seen not as a system level factor, but sometimes it's hard not to address that as an individual level factor. And so we've really tried to bring in some of our more experienced partners to start leading recruitment as we move forward. So again, those messages, emphasizing the importance of this work, emphasizing benefits to the clinic, and then extending our support. So really emphasizing again that this is something we'd like to work with them on, and we're here when they do have capacity to engage. So at a very high level in this slide, you can just see some of the changes or shifts in how we've been emphasizing our supplemental support. And so in the initial support column, you can see that sites have always had access to the SBIRT Oregon website. There's been a focus on facilitation, participation in ECHO, academic detailing. But what we've seen is that we need to more emphasize our support for health information technology. And although we thought there would be a strong hook because of the CCO SBIRT measure, we're finding that many clinics that had the ability to report that metric aren't interested in additional support because they've already met the target. But for those who have yet to be able to report that metric, the SBIRT measure isn't as much of a hook because of the way the financial structure works for the CCOs. Continuing to align with priorities, tailor to context. As I mentioned, shifting to some alternative reporting metrics for unhealthy alcohol use screening, and then offering those webinars, so the lighter touch options. We've also added an additional start wave with the intention now that we will hopefully be able to get a no-cost extension to continue engaging in this work. So quick summary. This has been, I think, just a really interesting learning curve in terms of how do you respond dynamically when the environment is changing so quickly. And this has impacted us in how we message to clinics, but also how we structure our overall project engagement. I think we have a lot of thoughts around strategies for team staffing in the future in terms of how we create the infrastructure for large projects like this. And then the main thing is remembering it's a marathon, not a sprint. So I think, although obviously we are very committed to seeing what we can accomplish in this project, practice-based research networks and facilitation has always been about holding relationships and helping clinics beyond individual projects. And so I think really part of what we're trying to think about is how do we be a resource and an ally given all the dynamic changes that are happening on the ground right now. So I want to give a special thanks to Tiff Weekly and Caitlin and our antecedent team, but also just to give a super huge thanks to Jan Delamar and Bob McNellis, who have been our project officers and I think have helped us try to process how do we respond to all of this in real time as well. So Sebastian, I'll turn it back to you.
Thanks so much, Melinda. So now we're going to have an opportunity to hear from all of you and to hear what you have to say, what questions you have, what comments, what experiences you have. We already have a few questions lined up in the Q&A box. I'm going to take moderators prerogative and ask one question that I think I have. I think we've heard a lot about so far the challenges that you faced in primary care research as a result of this pandemic. I wondered if you would be willing to share maybe some of the opportunities that have also arisen. Opportunities as a result of the pandemic that have kind of arisen that you think might transform primary care research in the future just because of the way things have happened.
Well, one of the key things is this has really offered a great opportunity to look at virtual facilitation. I mean, most of the studies that have been done previously really have been in-person facilitation. There have been a few that have tried virtual facilitation, but our level of experience with that was limited to a couple of small scale projects. I think practices certainly have become more facile with everybody in the world has become more facile with dealing with Zoom and other virtual platforms. And so virtual facilitation may really help us to deliver facilitation more economically in the future. And we have a natural experiment here to really look into that switch. So that's been a big advantage, I think, that has arisen a lot because of the pandemic. And it may change the way we do some of our projects in the future.
Yeah, I would agree. I would just echo, I think one of the main opportunities is I think a lot of the work our network does is with rural practices. And in the past, you would have never thought it was appropriate to recruit or contact clinics using a virtual platform. And I think COVID has really opened up so that that's normative. I think sites now have the resources, the technology, the capacity where a Zoom meeting is normal, as opposed to, I think in the past, that would have been seen as like culturally inappropriate to use those methods for engagement.
Thank you. So as a follow-up from one of our participants, one person has a question about recruitment in general. The question is, has anyone had luck recruiting practices through cold calling or cold emails, or has all recruitment been through existing relationships with practices? And to add to that, maybe like, what is the best way to now? Is there a change in the way that cold calling and cold emails, as you kind of hinted at, Melinda, has happened?
I would say, I think cold calling and cold emails have always been a strategy the network has used. I think there's a perception that it's always been more challenging to engage clinics that way. And I think some of that is because you're often trying to learn the lay of the land and to learn who has the right authority to make decisions. We've talked a lot with our advisory board in ORPREN about how do we optimize recruitment? And one of the things they've really emphasized is that you almost need to be contacting all levels of an organization. You need to approach clinicians, you need to approach administrators. So for that individual who asked the question, I mean, I think that's always been part of the plan. It's definitely gotten harder with COVID because people's capacity to even integrate new information, I think, is more limited. But also for the study team, there are some challenges just in terms of what's the groundwork you need to do to get to the people who can say yes. I know there's a really interesting manuscript, I think, that LJ Fagnan led from the original Evidence Now initiative, which highlights kind of the cost for recruitment, and that if there is a prior existing relationship, you're usually able to have success in that engagement sooner than if it's a novel contact.
Yeah, I would say pretty much the same. We always do a multi-pronged recruitment strategy. Our most successful recruitment comes through pre-existing relationships. We have, within Colorado, we have a partnership with a number of different organizations that work on the practices. Again, like what Melinda said earlier, we're fashioned in a way to give ongoing support to practices as much as possible. And many of our practices have worked with us on previous projects and kind of continue working with us through different projects. And so certainly, where we have either we or the organizations we were working with have that relationship already built in with multiple levels of the practice. That's the easiest place. We do cold calls. We do a lot of publication about our project opportunities through multiple sources. We have relationships with all the different professional associations in the state and send things out through them, and have an extensive network of practices that have either worked with us on projects or use some of our resources, even if they don't sign up for projects. So we do send things out that way, but I'd say most of our successful recruitment occurs through the in-person contacts from our staff or our partners.
Thank you. Another question is, how do you think the American Rescue Plan, which has significant investments in community health centers, will influence primary care practice research involvement?
I'm not sure if I have a great answer for that one yet. It kind of depends on how those investments are used. I mean, on one level, it'll prop up the community health centers to the point where at least maybe they'll have full staffing, et cetera. If there's particular deliverables that end up being tied to some of those investments, and I'm not really familiar with quite how that money is flowing in, but if it ends up requiring work on the parts of the practices, then again, that's a competing demand when it comes to recruitment and engagement in projects. So we'll see. I will say that some of our FQHCs have really been impacted by all this, on multiple levels. And in particular, they've been working on vaccine delivery more earlier and more actively than the other private practices. Many of our private practices grew frustrated because they weren't incorporated into the vaccine delivery plans, but many of the FQHCs actually were early on and had very active engagement there to a point where that became a competing demand as well.
And I would say the same. I think we're watching and waiting. I think there's always an opportunity as new resource comes in, but again, the clinics are still recovering. So who knows if they'll have additional bandwidth in response even to that influx of support.
Great. One other question that's somewhat different is, are there specific skills that practice facilitators need to be trained in order to be able to do facilitation virtually? We mentioned that as an opportunity, but are there things we need to be doing in specific to make sure that's effective?
I think the easy answer is yes, Perry, because you guys had this as one of the focuses of your initiative. Maybe you have some scientific responses. I think this is actually a great opportunity for research. Obviously, there's a need for research on telehealth and what makes a telehealth encounter successful, but I think the same thing in facilitation. Facilitators, I think, have always been good at responding to challenges in real time. So often you'll go to a clinic and maybe you have an hour meeting planned and it'll turn into a 15-minute meeting because of backlog and scheduling or what happened in the day. And I think in virtual, part of what's interesting is I think you need a different dynamic sometimes, right? It's hard to read the room. You might not know who all the players are. They might not be on the video. I think technology is a huge challenge. We've had facilitators who you might have a meeting set up and then you turn and you have to do it by phone. So you end up facilitating by phone. I think this is just a great opportunity. There's so much opportunity to learn more beyond what an impression is for what's effective for virtual facilitation and what maybe scientifically is really effective and why.
Yeah, Melinda, I completely agree. We've really tried to learn as much as we can around this whole transition to virtual facilitation and what makes it work, where it doesn't. All those sorts of things. One question there is whether it works better in situations where you do have a pre-existing relationship between the practice facilitator and the practice to where you know the people. Always before, even when we were looking at virtual facilitation in our prior design, we were going to have make sure that the practice facilitators had a couple of visits with the practice just to have some interpersonal contact there. And I think for practice facilitators who really build on their relationships with people, I mean, they're people, there are people who really are good at building in-person relationships. You know, the switch over to virtual was really disturbing for some of them. We see differences from across our practice facilitators in terms of who has done well with it and who has struggled. There are things that have come up like, you know, when you're showing up in person to a practice, even if the practice has completely forgotten that they're supposed to meet with the practice facilitator, you can still engage them usually, almost 100% of the time. When you show up to a Zoom meeting and no one's there, there's not a heck of a lot you can do. So there actually are some aborted meetings that way. So there's all sorts of little tricks to managing virtual facilitation that we're continuing to learn. And we have regular learning community calls with our practice facilitators where, you know, part of the focus is what are you learning in terms of practice facilitation virtually, and kind of how should we incorporate some of that into the design. One of the things we're about to do, we're just getting the IRB approval for interviews of our practice facilitators and some of our practices around the experience of virtual facilitation. We're taking advantage of a little bit of a lull here in practice engagement to really go to the practice facilitators and practices that have already completed things and look at that specifically and try to see what the lessons learned are. So again, we're making lemonade out of lemons, but I also think there's a huge opportunity there. But there are things that we have are going to have to deal with in terms of how we train practice facilitators in the future.
I'll just jump in because I think it's worth noting one of the other shifts we've seen in the last year is the use of cell phones and texting your clinical team members. To me, that is like a mind-blowing transition where that was never a data point or information I was trying to get. But I would say, you know, now texting's normative. And I would say to Perry's point too, that's one of the things too, is sending out those reminders through those mechanisms that people are used to using. So another really interesting shift.
Thanks. One question here is comparing baseline data to post-intervention data when the baseline may not be typical because it was pre-COVID. I don't know if either of you collected any baseline data before COVID for this project or another project, and could speak to how do you compare a baseline that's maybe not normal to the post-intervention data that's now post-COVID?
We have a couple of different types of data that we're collecting, one of which really looks at the implementation of the different elements of screening, brief intervention, medication-assisted treatment, and referral to treatment. You know, kind of what they're doing at baseline, and then how that changes in terms of their implementation across time. And I'm really, really grateful that we have that, because I think that may end up being one of our best measures. The measures that we're collecting around, you know, kind of their actual performance in terms of screening and brief intervention, all those sorts of things, I think have been disrupted a bit, particularly by by the move to telehealth. I think although we've worked with both the practice facilitators and the practices around how to make sure that they're capturing it, no matter how they're doing the visits with the patient, to make sure that they're collecting the information in a way that we can pull it out. But there's pretty much no question but that for practices that were enrolled kind of during that whole period of the initial stages of COVID in particular, there's major disruption in some of the measures. I am very thankful that we're not doing any clinical quality measures, because I know that for most practices, those have been very much disrupted by COVID. So, you know, it kind of depends on what you're collecting as measures.
Yeah, and I would say the same thing. I think that's been a big discussion in our team is obviously we had an initial evaluation plan in place, and that comparatively has been kind of thrown out of the water. What I might do, Sebastian, there's one other question from Cindy Brock, which I think is important, which is around disparities. And maybe I'll just get on a soapbox real quick, because I think the challenge with all of this is that the data is really hard to access and acquire. So many of the clinics aren't currently reporting, especially as you move into clinics with non-traditional EHR systems. They're often having to build these queries and build the entry platforms on their own. The issue with disparities is that you don't even have the basic data, and then let alone to add in like cuts in terms of patient demographics. It's a huge challenge. I think also from a research perspective, the numbers in a lot of these clinics, as you start to make those cuts into different population subgroups, are really small. So there's also this interesting like tension between the importance of looking at disparities and then how many of our robust research designs are, we don't have the power then to look at those smaller subgroups. So super critical, something our team has been talking a lot about, and just maybe making a push that we need to recognize that these are smaller populations, especially as you're working with smaller clinics, and to think about new measures that are normal when you're working with those smaller population groups.
So Perry, in case you didn't see the question was around how do you make sure you're able to address disparities as you recruit practices? I think we've seen for sure that COVID has really brought to light a lot of disparities within how COVID, like the prevalence of COVID, how people are treated now with the vaccine distribution. Are there other thoughts in terms of studies and recruiting that we're seeing with disparities?
Yes, I think probably there's been a little bit of a differential impact on on the practices we're able to recruit as well. If you look at some of the smaller rural practices that didn't have system resources or whatever, particularly for moving over to telehealth and quickly and all, they probably have suffered a little bit more from a financial perspective and have been a little, because of the impact on those practices as well, they've been more difficult to recruit. So practices that were really serving some of the underserved populations, I think have been impacted more through COVID than some of the others. Yes, I think it has had an impact. We have really focused on some of our community health centers and some of those practices in particular, looking at how we can support them in engaging. But we also are being very careful because we don't want to disrupt them excessively at this point.
And I think in terms of, again, recruiting a lot of those regions, we have a few communities with high populations of migrant and seasonal farm workers, and those are often the settings that they've had kind of the bigger COVID outbreaks in the rural areas. And so again, it's we are trying to look and to prioritize outreach to those settings, and yet, yeah, it's an accumulation of stressors that makes it really hard for these sites to participate. Great question.
Well, we're coming to the top of the hour. So I wanted to thank both you, Melinda, and Perry for participating, for preparing a great presentation and being open to answering questions from the audience, to hear just about your experience of primary care research during COVID-19. Thank you so much to everyone else for participating, for being engaged, for asking questions. We're gonna make this webinar available online as soon as we figure out a place for it. And there was one question about whether we'll share the slides as well. If that's okay with Perry and Melinda, we're going to share the slides for this presentation so that people can see what experiences at least 2 of our 6 unhealthy alcohol use grantees have had. Well, so thank you so much for everyone for being a part of this, and have a great rest of the afternoon. Thank you.
Thanks, Sebastian.
Thank you.